Bismillah ar-Rahman ar-Rahim. I am Dr. Ijaz Ahmad Khan, and I'm going to present my topic. Let me just share with you a screenshot. So I don't know if you can see. So my topic is approach to pulmonary infections in neutropenic pediatric cancer patients. I have no disclosure. This is an overview of my topic, which is I'm going to talk about a brief introduction, give you a differential diagnosis of lung infiltrates, talk about specifically pulmonary infections in neutropenic child, radiology in opportunistic infections, approach to infiltrates in neutropenic child, and what are some of the diagnostic considerations, and what are the different interpretation of diagnostic tests. And then lastly, key management recommendations related to child with the lung infiltrates with neutropenia. So we know that infections frequently complicate the treatment course in children with malignancies undergoing chemotherapy. Febrile neutropenia remains a major cause of hospital admissions, and febrile complications in cancer patients are common if high-risk neutropenia persists, especially a count which is less than 500 for more than 1 week to 10 days. We also know that respiratory tract are common site of infection with few signs and symptoms in a child with neutropenia. It is estimated that the risk of lung infiltrates is about 20 to 25%. Clinical presentation may be subtle. If you are not careful, then there is a high risk of treatment failure and fatal outcome. Etiology, unfortunately, remains undetermined in most cases, especially if you have limited diagnostic capability. However, since 1990s, there has been a lot of advances in diagnostics, a lot of new and novel therapy, antifungal, antivirals, and of course, very good supportive pediatric critical care that has improved survival in these children. Talk about differential diagnosis. If you talk about mostly non-infectious causes, then you can see that the lung itself, the airway, chest wall involvement in primary malignancy can occur. These include some of the rare tumors in pediatrics, such as pleuropulmonary blastoma, which can present as chest masses, and carcinoid tumors, which can present with endobronchial obstruction. All these tumors, which are mentioned here, and the specific areas that are involved, it can cause significant problems such as air obstruction from large mediastinal tumors or lymph nodes. Chest wall may be involved in primary malignancies. And of course, you can have large malignant pleural effusions. Then you can have metastatic disease with primary involvement in other organs, such as Wilms tumor, osteosarcomas, Ewing sarcoma, and other tumors. This is an exhaustive list in tabulated form, different tumors in the specific age group, clinical features, pathologic features, and genetic markers, and of course, imaging features. Unfortunately, this is not very clear, but I can assure you this looks a very good table to look at. Pleuropulmonary blastoma can present with this cystic-like lesion, and you can have malignant pleural effusions. You can have a CT scan of a child with a large stage 4 Wilms tumor. And you can see these roundish lesions and pulmonary metastases of osteosarcomas. And of course, Ewing sarcoma involving the chest wall. Then the other differential that you should think about is acute lung injury from chemotherapy and radiation. Children can get these side effects. Then can be pneumonitis, frank pneumonitis due to radiation up to 15% of patients. However, with modern radiation dosing and targeted radiation, these are minimal. The risk, however, remains significant with late pulmonary effects. And of course, there is an increased risk of radiation pneumonia with certain drugs, such chemotherapeutic drugs such as bleomycin, dactinomycin, adrimycin, and actinomycin D. Radiation injury may also affect subsequent lung and chest wall growth. The other differential diagnosis you have to think about is cardiopulmonary complication of cancer chemotherapy, which, as mentioned above, can be late. Cardiac toxicity, specifically with anthracyclines, is dose dependent. And of course, I mentioned that large chemotherapy agents can cause late pulmonary injuries. And these are mentioned here, some of the drugs. If you look at the timeline of non-infectious complications, specifically in organ and hematopoietic stem cell transplant, then you can see that in the first few months, you can have pulmonary edema, veno-occlusive disease, diffuse alveolar hemorrhage, idiopathic pneumonia syndromes, and of course, graft versus host disease, which can be acute and chronic. After 3 months, you can begin to see interstitial lung disease, post-transplant, lymphoproliferative disease, and bronchiolitis obliterans. This is a slide which unfortunately you cannot see clearly, but it gives you treatment exposure and the potential late effects and the risk factors associated with these different treatments. This includes radiation, alkylating agents, and of course, surgery. If you look at hematopoietic stem cell transplants, there are pulmonary complications which can occur. We know that these complications are diverse. It can cause acute therapy. During acute therapy, you can see or appear later in life during the course of therapy. Pre-treatment with chemo or radiation, of course, can also lead to lung injury. This specific article mentions about 42% of hematopoietic stem cell transplant subjects developing pulmonary complications, and most of them are related to T-cell depletion, acute graft versus host disease, and chronic GVHD. And of course, if you see pulmonary complications, the risk of mortality increases 2.8-fold. Now, coming to the infectious complications, can be a major cause of morbidity mortality, usually classified according to a time period after transplant. And the differential diagnosis, as mentioned already, you can think about underlying malignancy, which can be primary lung or chest wall related, or it can be metastatic disease. And of course, treatment can also cause chemotherapy or radiation can cause lesions which are similar to infectious complications, capillary leak syndromes, cryptogenic organizing pneumonia, and immune reconstitution syndrome as well. We know that opportunistic infections are common in children with immunosuppressive conditions, specifically neutropenia. And of course, this is referred to as organisms that are typically seen primarily in patients with compromised immune status, such as neutropenia or decreased T and B cell immunity. Common respiratory viruses and bacteria and less fungi commonly can be seen, and there can be atypical and multi-resistant bacteria. Filamentous fungi are common, Pneumocystis jirovecii, different viruses, Staphylococcus multifiliae, resistant organisms such as Acinetobacter and other Enterobacteriaceae. This is a nice table talking about typical pulmonary pathogens associated with acquired immune deficiencies, disease states such as neutropenias. If you look at neutropenia as underlying condition, it can be acute, chronic, and immunosuppressive, or during the immunosuppressive state. So you can see different bacteria such as Haemophilus, Streptococcus pneumoniae, Staph aureus, Klebsiella, Listeria, Mycobacterium associated with different status of the neutropenia, or whether it's acute or chronic. Different fungi can be associated with immunosuppressive therapy, Aspergillus, Mucor, and as of course, specifically for viral protozoal, we know that CMV, Pneumocystis jirovecii, Toxoplasma, Cryptococcus, herpes, they can cause pulmonary infections. Bone marrow transplant, I'm not going to take in detail, but early, late, and very late can be associated with different bacterial, fungal, and viral etiologies similarly. Opportunistic and usual common pulmonary respiratory infections in childhood cancer patients. These are already mentioned above, but these can have catastrophic condition, pulmonary infections. And we know that we should be aware of CMV, Pneumocystis, fungi, Candida, Aspergillus are commonly seen different stages. But remember also common bacterial and viral pathogens. Never forget these: Staph aureus, influenza, RSV. Many neutropenic children with acute respiratory failure experience worsening of their oxygenation during neutrophil recovery. We know that because during neutrophil recovery, you get what we call kind of an immune reconstitution syndrome, and it can worsen inflammatory response in the lungs. These are more pictures of radio imaging of the chest in different opportunistic infections. This is Staphylococcus multifiliae, bilateral ground glass opacities, numerous central lobular nodules, diffuse cylindrical bronchitis. You can see this is already here pointing the black and white arrows. Pneumocystis jirovecii is another opportunistic infection can be a cause of pneumonia in neutropenic children. So you can see bilateral butterfly-like appearance of infiltrate with hypoxia. MRSA or Staph aureus can cause devastating lung infiltrates with a CT scan showing multiple bilateral nodular cavity lesions. Viral pneumonias, as I talked about, are another opportunistic infection which can cause diffuse bilateral changes seen on the plain X-ray and also CT scan. Fungal infections such as invasive pulmonary aspergillosis can be seen as nodular infiltrates with peripheral, nodules which are peripherally or pleural based, and it can also involve the lungs. And you can see this depiction of what is called as a halo sign. Mycobacterium tuberculosis, of course, can present with different aggressive looking infiltrates seen as collapse consolidation with multiple redilution cavities. How to approach? This is a a table talking specifically about hematopoietic stem cell transplant. And remember that you can have different infiltrates, and you have to be aggressive. And that's this approach talks about being aggressive, talked about use of invasive procedures such as bronchoalveolar lavage, especially with different clinical condition, worsening conditions. If you have progressive pulmonary dysfunction, you may need early non-invasive ventilation, or you can need mechanical ventilation, in which you can use different strategies to manage these children. And of course, you can use high frequency ventilation, ECMO, and of course, a lot of them will require ICU care. After recovery, of course, you should be aware that they need pulmonary function test, prophylactic antibiotics, vaccination should be given. All that is available, and these include different pneumococcal and influenza vaccines. Another table talking about a child with neutropenia, fever, and suspected lung infiltrates. If a child has failed therapy, oral or IV therapy with persistent fever, it is recommended that you should be more aggressive with the CT scan. And you can see that if there is no lower respiratory tract infections, then you can be don't need to be more take new steps. But of course, if CT scan is pathologic or a plain X-ray is looks very atrocious, then you should be very aggressive with your non-invasive and invasive procedures such as bronchoscopy and BAL. And the BAL will determine how you respond management. So you can give a preemptive therapy if your tests are negative or not feasible, or you can have a targeted therapy if some of the test becomes positive. And of course, you see the clinical response and with a follow-up testing. These are recommendations specifically talking about imaging. So in neutropenic patients with signs or symptoms of lower respiratory tract infection, HRCT is the diagnostic method of choice. So there is evidence A2 for that. Conventional chest X-ray are usually not recommended, at least in the child with progressive disease or who have failed your usual therapy. In most cases, thoracic CT scan can be done without contrast media. HRCT must be available within 24 hours after clinical indication has been established, because you want to be aggressive, you want to look at the lungs films and to take your next step. And if infiltrates are detected on pulmonary CT scan, BL should be carried out at a segmental bronchus supplying an area of radiographic abnormalities. And you should compare your CT scan with previous scans. That's what what about recommendation for bronchoscopy and bronchoalveolar lavage? Bronchoscopy and BAL should be carried out using a standardized protocol. Transbronchial biopsies are usually not recommended in such children because of possible bleeding and side effects, especially with thrombocytopenia. If a tissue sample for histology is collected, then microbiologic and molecular workup is required. CT-guided percutaneous biopsy, video-assisted thoracoscopy, or open lung biopsy should be used. Microbiologic workup of BL should be followed a standardized protocol. For example, in our setup, we usually send for cytology, for PCP stains, for fungal and AFB and routine stains, and then a fungal culture, AFB culture, routine culture, and then MTB PCR. The other recommendation is urgent need to start or modify antimicrobial therapy should not be postponed by bronchoscopy or BL. So you can start your therapy early on. Bronchoscopy and BL should only be carried out in patients without critical hypoxemia. The stable patient should go this procedure. Now, once you have done your BL and you're successful, you should be doing the following testing, as I told you, and these include cytospin, gram stain, Giemsa stain, mycobacterium PCR, PCR for pneumocystis if you have it, DFA for pneumocystis jirovecii, aspergillus antigen, which is called galactomannan. I'm pleased that galactomannan is now becoming available most setup. And then, of course, don't forget your bacteriological cultures, quantitative and semi-quantitative. And you can use different media for that. You should use, for mycobacterium, you should use at least one solid, one liquid media. Then, of course, for fungal seborrhea or equivalent fungal culture, media should be used. There are optional other tests or facilities that you can use for enrichment of for making yield more helpful, such as brain, heart, infusion broth, Legionella PCR, PCR for CMV, RSV, etc., influenza, adenovirus, etc. And of course, then a peripheral blood culture is also recommended after bronchoscopy to detect transit bacteremia. If you see positive bronch, then specifically the following are indicative of pathogens causing the most likely lung infection. These include pneumocystis jirovecii, gram-negative aerobic pathogens, pneumococci, nocardia, MTB, aspergillus galactomannan, mucor, etc. And isolation of pneumococci, alpha-hemolytic streptococci, bacillus cereus or gram-negative aerobic pathogens from blood culture. Any detection of pathogen with invasive growth and biopsy material. Then a positive aspergillus galactomannan in blood, etc. On the other hand, the following do not represent pathogens causing lung infection. These are enterococci from blood culture, swabs, sputum, BL, Coagulase negative streptococci, corynebacterium from any sample, isolation of Candida from swab, saliva, sputum, tracheal aspirates. Remember that these can be possible cause of infections elsewhere, but not specifically in the lungs. What about management or clinical management? For febrile neutropenia with low respiratory tract involvement, not typical for PCP or lobar bacterial pneumonia, should receive more elective systemic antifungal therapy. The preferred first-line therapy in this setting is voriconazole or liposomal amphotericin B. We don't have liposomal, but you can use conventional ampho instead. But I would prefer voriconazole in a first setup unless you suspect mucor. The dosage is usually the same as for proven mold infection, which is about 1 milligram per kg, 50 to 75 milligram in most setups. In severely neutropenic hospitalized patients, antiviral agents, macrolide, antibiotics, aminoglycoside, fluoroquinolones should only be given for proven or conclusive microbiologic findings. If PCP is suspected based on lung infiltrates and new LDH elevation, treatment before bronchoscopy or BL can commence. First line choice for treatment of PCP is high dose trimethoprim sulfamethoxazole. If PCP patients are intolerant or refractory to high dose ampicillin trimethoprim sulfamethoxazole, the other option is clindamycin with primaquine. You can, this is available in Pakistan. In non-HIV patients with non-critical respiratory insufficiency, adjunctive steroids is not recommended. Patients who have been successfully treated for PCP should receive secondary oral prophylaxis. And drug of choice for secondary PCP is intermittent trimethoprim sulfamethoxazole or pentabidine aerosolized monthly. For Pseudomonas pneumonia, treatment with anti-pseudomonal beta-lactam plus aminoglycoside is recommended. Anti-pseudomonal beta-lactams for Pseudomonas include piperacillin, tazobactam, ceftazidime, imipenem, celestatin, meropenem, and cefepime. Alternative to an aminoglycoside is respiratory quinolones such as ciprofloxacin for anti-pseudomonal additional coverage. The preferred regimen for documented Stenotrophomonas maltophilia is trimethoprim sulfamethoxazole. The dose of trimethoprim sulfamethoxazole is similar to treatment for pneumocystis jirovecii pneumonia. For CMV ganciclovir, a response should be assessed clinically. However, imaging should be done after 7 days of antimicrobial therapy and not before that. Usually, I see a lot of our patients getting daily chest X-ray, which is extremely wasteful of resources. In patients with lack of clinical improvement, CT scan should be repeated after 7 days of treatment. Persistent fever, progressive or newly emergent infiltrate after 7 days warrants more microbiologic diagnostics and change of therapy. Intensive care should be unrestrictedly provided to patients with respiratory failure. And of course, you can involve other colleagues in your care of such a patient who has failed therapy. In conclusion, pulmonary involvement is common in children with neutropenia. Many common and opportunistic etiologies can be the cause of lung infiltrates. Outcome can be detrimental. Diagnostic challenges exist for opportunistic infections, especially in a lot of settings in which we have limited capabilities in diagnostics. However, early aggressive diagnosis and management is imperative for good outcome. Specific antimicrobials must be selected in neutropenic patients. Thank you very much. I will end here. And if you have any questions, I will be more than happy to answer that.
Thank you very much, Professor Ijaz, for a wonderful talk and guiding us how to approach a neutropenic pediatric patient with pulmonary lesions. We'll have question answer sessions at the end of the presentations, and I will request everyone, if you have any questions, please ask in the chat box or in the question and answer section. So now we will move on to our next speaker. Our next speaker is Dr. Anam Abbas. She is a consultant in infectious diseases and assistant professor, Department of Internal Medicine in the University of Nebraska Medical Center, Omaha, in the United States. And she has special interest in infections in immunocompromised hosts, infection in stem cell and solid organ transplant recipients. And she'll be giving us an overview of candidal infections in cancer patients. Over to you, please.
Hi, and Assalamu alaikum. My name is Anam Abbas. I'm an infectious disease physician here at the University of Nebraska Medical Center in Omaha, Nebraska in the US. I practice immunocompromised ID, and my practice consists of seeing oncology patients, both solid organ tumor and hematologic malignancies, recipients of hematopoietic stem cell transplant, as well as other cellular therapies, including CAR T cell. It's an absolute pleasure and honor to be able to speak at the Shaukat Khanum Cancer Symposium. So I really thank you for your time today. Today I'll be talking to you about candidal infections in oncology patients. I have nothing to disclose. And so hopefully by the end of this talk, what we'll be able to do is determine some of the risk factors for candidal infections among cancer patients, distinguish some of the trends in Candida species that cause infection, describe some of the clinical manifestations and spectrum of disease of Candida infections among cancer patients, and then be able to describe some of the available diagnostic methods and some of the important management principles when dealing with invasive candidiasis. And so I'd just like to outline briefly sort of what we'll be going through today. I'd like to start off by giving some background and introduction and epidemiology, sort of really describing the burden of disease in our patient populations and some of the host risk factors, and then discuss some of the clinical syndromes and spectrum of disease, followed by some of the just really important management principles and strategies when it comes to invasive candidiasis. And so, unfortunately, as you all are aware, cancer is still a leading cause of death worldwide. The WHO reported that in 2018, there were 18.1 million new cancer cases, with 9.6 million deaths secondary to cancer. You can see Asia carries a large proportion of these patients. And so, unfortunately, we still have a very high global burden of disease as far as cancer goes. And chemotherapy is the primary therapeutic intervention that we have for cancer, but unfortunately, this oftentimes increases our risk for opportunistic microbial infections. Candidemia is still one of the most common causes of bloodstream infections in cancer patients. The average annual incidence of systemic candidiasis in cancer patients ranges anywhere from 71 to 2,400 per 100,000 admissions. And this is compared to 10 to 370 per 100,000 admissions compared to the general hospital population. And so what makes these patients more at risk for fungal infections and candidal infections? And what we know is that our oncologic patients have several risk factors that place them at increased risk for fungal infections. Of course, first and foremost, neutropenia is an important risk factor for these patients with infection, especially fungal infections, as well as candidemias. Lymphopenia is an important risk factor, and oftentimes these patients will be neutropenic either from their disease, if they're a hematologic malignancy patient, or related to the chemotherapy that they're receiving. Mucositis is an important risk factor, the disruption of the normal mucous membranes from chemotherapy, damage from chemotherapy, or the presence of any GI malignancy. Oftentimes, these patients will have central venous catheters, which become colonized and become an itis of infection. They'll be receiving steroids, which further immunosuppress them and place them at increased risk for invasive candidiasis, as well as total parenteral nutrition. And unfortunately, our patients the oncologic population often has one or multiple of these risk factors, placing them at increased risk for infection. And so we understand that neutropenia is an important risk factor when it comes to infection. We often see prolonged neutropenia in hematologic malignancies, in hematopoietic stem cell transplant recipients, or even other cellular therapies, and sometimes even with cytotoxic chemotherapy. And what we know is that the longer the duration and depth of neutropenia, the longer the risk for infection. Specifically, when we talk about duration of neutropenia, the longer the duration of neutropenia, the higher the risk they are for invasive fungal infections, specifically invasive mold infections, but also candidal infections. And so chemotherapy increases the risk for systemic candidiasis in cancer patients. This is a nice diagram that sort of demonstrates some of these effects. On the left, you can see sort of the unperturbed state, a normal host. And on the right, you can see changes that can occur with chemotherapy. And so some of the immunosuppressive effects of chemotherapy can result in less of those effector cells. So you may have less circulating neutrophils, lymphocytes, and some of the other white blood cells. And so your host defenses are weakened that way. There's also a breakdown of the epithelial barrier. And so there's disruption that way, and this can result in invasive candidal infections. And then there's this question of disruption of sort of a normal microbiota, which promotes further growth of Candida and may result in overgrowth and promote invasive candidiasis. And so many of these different effects, and sort of probably a combination of these different effects that chemotherapy can have on the host, can promote an environment making them susceptible to candidal infections. And so now that we have a little bit of an understanding of some of the specific risk factors that the oncologic population, that are present in the oncologic population, let's just briefly review some of the classification of fungi before we discuss specifically Candida. So where does Candida fall as far as in the kingdom of fungi? So fungi are classified either as yeasts, filamentous fungi, or molds, or dimorphic fungi. So our talk will focus on Candida today, which of course are yeasts. They're round or oval shaped. The Candida specifically produce these blastoconidia, which can end up looking like pseudohyphae, and they reproduce by budding. We won't be talking about filamentous fungi or molds today. For example, Aspergillus, Mibralis order, Fusarium, Scedosporium, or dimorphic fungi, which of course grow as yeasts at body temperature and can grow as molds in room temperature. And some examples of dimorphic fungi include blastomyces, coccidioides, histoplasma, and paracoccidioides. But we will be focusing our discussion on Candida today, which of course is a yeast. So Candida is ubiquitous in nature. This Candida is part of our normal human flora in our GI tract. It's on our skin, and it causes a really wide clinical spectrum of disease, from local infection in an immunocompetent host to invasive candidiasis and even some chronic disseminated forms. But what we understand is that the immune status of the host is an important factor when it comes to the different types of spectrum of disease that we'll see with candidiasis. Candida infections are seen in both solid cancers and hematologic malignancies. This paper looked at cancer patients from 2009 to 2012 and identified candidemia episodes and found that most of the infections were seen in head and neck cancers, followed by GI malignancies, lung cancers, and then hematologic malignancies. So again, we will frequently see candidal infections both in solid tumor and hematologic malignancies. In solid tumors, we'll see them most of the time in head and neck, as well as GI malignancies, probably representing where Candida is a colonizer and then becomes an opportunistic pathogen at these sites. As far as hematologic malignancies, most of the time seen in these malignancies that will result in, again, profound and prolonged neutropenia. And actually, prior to the introduction of azole antifungal prophylaxis, candidemia was a very common problem among hematologic malignancies. This study from 1999 showed that cancer was the most common underlying condition as far as patients with candidemia, and this was followed by abdominal surgery and diabetes. And since then, we've sort of seen a decline in the incidence of bloodstream infections, but we have seen a proportional increase in infections caused by non-albicans species. So with the advent of azole prophylaxis, we've seen a sort of shift in species, this type of species causing disease. And so let's just go over some of the Candida species briefly. Candida, as you know, you're probably well aware of some of the more common species, Candida albicans and glabrata, but there are actually many non-albicans species that exist that are pathogenic in humans and cause disease. And there was an interesting study that sort of looked at the overall evolving landscape of Candida infections in hospitalized patients, and the results were pretty interesting. What they found was that they used a registry looking at invasive fungal infections and analyzed candidemia episodes. And they found that collectively, candidemia was caused by more commonly caused by non-albicans species versus albicans alone. And so that's really a shift of what we've seen in sort of the earlier eras. Also interesting in this paper, they noted that Candida krusei was most commonly associated with hematologic malignancies, hematopoietic stem cell transplant recipients, neutropenias, and carried the highest crude mortality. And so sometimes the species that we're dealing with may give us important clues. And so what we see now is that some of these uncommon Candida species are on the rise in cancer patients. We've seen a shift of human infection from albicans to non-albicans over the past 2 decades. This study from MD Anderson showed that the incidence of bloodstream infection caused by uncommon Candida species doubled during the past 16 years, as well as the proportion of these species causing candidemia also doubled. And so you can see the figure on the left. The white bars represent the later era, 2006 and 2013, and you can see a significant increase for some of these uncommon Candida species when you compare to earlier eras. The shift is most likely hypothesized due to widespread use of azole antifungals, as well as more widespread use of echinocandins in some of these more high-risk populations. So really sort of seeing an evolving landscape of the type of species that we're seeing causing disease in these patients. Again, just some species-specific pearls when it comes to Candida. So Candida glabrata, of course, is the second most common Candida species. It exhibits a reduced susceptibility to azoles. A lot of times these isolates are resistant to fluconazole, and even if they are sensitive, they may have elevated MICs, and so they may have a dose-dependent susceptibility to fluconazole. Most of these are susceptible to echinocandins. Candida krusei, we mentioned. This is one that's oftentimes associated with hematologic malignancies as well as stem cell transplant recipients. This is intrinsically resistant to fluconazole, but is susceptible to echinocandins. So that's important to know when you're starting empiric therapy that Candida krusei as a species is resistant to fluconazole. Candida propylosis is an interesting species. It produces biofilm, and so it's oftentimes associated with line infections, implantable device infections. Also, interestingly, Candida propylosis exhibits an increased MIC to echinocandins. Candida lusitanii is one of the rare fungi and Candida species that is intrinsically resistant to amphotericin B. And of course, we could not go without mentioning Candida auris. Candida auris is an emerging global pathogen. It's something important that we kind of have to keep an eye on, as Candida auris is resistant to, almost all strains are resistant to fluconazole. 50% of these strains are resistant to one or more classes of antifungals, and sometimes pan-resistance has been seen. Candida auris can cause invasive disease, deep-seated infections. Mastoiditis and automycosis have been reported with Candida auris. So definitely something to keep an eye on. It is an emerging pathogen, and so hopefully not, but maybe something that we see in the coming years. And so, as you know, Candida can really cause a wide spectrum of disease, and this really sort of is dependent on host factors, as we've mentioned. Disease can vary from just local mucocutaneous infections, sort of manifesting as thrush or esophagitis, mastitis, sometimes vaginitis, to invasive candidiasis with candidemia, possibly retinal involvement, with endophthalmitis, bone and joint infections, endocarditis, intra-abdominal infections, as well as some chronic disseminated forms such as hepatosplenic candidiasis. Candidemia, of course, we are referring to Candida in the bloodstream, and this is most commonly caused by Candida albicans, followed by Candida glabrata. These are the most commonly implicated species. Some of the risk factors, which we've sort of gone over, include mucosal breakdown. So when it comes to our oncologic patients, either due to mucositis from their chemotherapy, presence of central venous catheters, or an underlying GI malignancy. Neutropenia is an important risk factor, oftentimes seen in our hematologic malignancies or stem cell transplant recipients. And also factors that favor the shifting of the microbiome to favor Candida species. So broad spectrum antibiotic use in these patients and total parenteral nutrition are important factors to consider. And so the clinical presentation when it comes to candidemia or invasive candidiasis is really similar to bacterial sepsis. And so patients will present with fevers, sometimes hemodynamic compromise. It differs from bacterial sepsis in that there's often a delay in diagnosis. And so it can oftentimes be associated with a very high mortality. And of course, there are important complications to remember, not limited to eye involvement in the form of chorioretinitis, as well as endocarditis. As far as our diagnostic methods, routine blood cultures should recover Candida, but may take a little bit longer, sometimes 2 to 5 days to grow. And 50% of the time, we may miss Candida on our routine blood cultures. We now have rapid PCR-based testing, which can be run on blood cultures, and these PCR-based tests can sort of identify your most common offenders, bacterial species, including as well as Candida species. Fungitel or 1,3-beta-D-glucan assay can be an important adjunct as far as diagnosis of invasive candidiasis. 1,3-beta-D-glucan is a cell wall is a component of fungal cell wall. This test can be positive in candidiasis, but it's not specific to candidiasis. It can also be positive in invasive aspergillosis, pneumocystis, as well as histoplasmosis and some of the other dimorphic fungal infections. It generally performs well in hematologic malignancies, but you have to be wary of some false positives that can occur with either colonization or blood transfusions, dialysis, and even some beta-lactam antibiotics. Fungitel is always negative in mucormycosis and cryptococcal infections because these fungi do not contain 1,3-beta-D-glucan in their fungal cell wall. And some important pearls to sort of remember when we're treating a patient with invasive candidiasis. There's just some important management principles to keep in mind. In cases of candidemia, we must always remove the central venous catheter. This is usually a point of no compromise because this ends up being a persistent source of infection in these patients. And so usually if they have any central lines, they've got to go. You really don't want to delay empiric antifungal therapy because this causes poor outcomes and increases mortality. Here we start empiric micafungin when we have cases of candidemia until we have identification of the species and sometimes susceptibilities as well. You definitely would like to repeat blood cultures to document clearance of infection. An ophthalmologic exam is recommended. If the patient is neutropenic, we'll oftentimes delay this until they have recovery of their counts, so that you don't miss anything as far as your dilated eye exam goes. We would recommend also at least a transthoracic echocardiogram in cases of candidemia. If you do have retinal candidiasis, either azole or amphotericin B with flucytosine is oftentimes indicated, and you may need a vitrectomy. And then again, I'd like to review some of the treatment in these immunocompromised patients when it comes to the different candidal manifestations. So if we're dealing with just oropharyngeal candidiasis or thrush, it can be sometimes treated just locally with clotrimazole troches or a nystatin or even fluconazole for a week to 2 weeks. With esophageal disease, usually you require fluconazole for a longer duration. Usually we'll treat these patients for 3 weeks. And you may want to consider an EGD depending on their underlying state of immunocompromise to rule out other infectious causes of esophagitis like HSV or CMV. Again, with candidemia, you are usually needing to treat with an echinocandin or liposomal amphotericin B. We treat for a minimum of 14 days from clearance of their blood cultures and also keeping in mind resolution of their neutropenia. Again, you need to remove any catheters, identify any other foci of infection, obtain a dilated eye exam, and at a minimum a transthoracic echocardiogram. With some of the more chronic disseminated forms of candidiasis, you require systemic therapy with an echinocandin, liposomal amphotericin B. Duration oftentimes is several months until you have improvement of some of the lesions. And then I did want to mention respiratory. So Candida pneumonia is not a well-defined syndrome, and it's often difficult to sort of tease out because Candida colonizes our oral mucosa, and so recovery of this on a sputum culture does not indicate disease. And so in general, Candida does not cause pneumonia, and if we have recovery of this on a respiratory specimen, we do not treat these with antifungals. And lastly, I did want to mention one important entity in oncologic patients, mostly something that we see in hematologic malignancies, but hepatosplenic candidiasis is an important diagnosis to be aware of. And what this is chronic disseminated candidiasis, which is seen in patients with hematologic malignancies. And what you will see is, you'll see this in neutropenic patients that have just recovered their counts. And these patients will present with persistently high spiking fevers, sometimes right upper quadrant pain, nausea, and vomiting. And you'll be treating them, they'll usually be blood culture negative, and you'll be treating them with empiric antibiotics, and they won't be improving. And if you obtain imaging, what you'll see is microabscesses in the liver, the spleen, and sometimes even the kidney. And so again, important things to sort of remember with hepatosplenic candidiasis. Again, neutropenia is the most important risk factor. Usually you have involvement of the liver and spleen, and timing from when they recover their counts is an important clue. Treating them with antibiotics and persistence of fevers is another clue. And treatment is usually with a systemic agent, either an echinocandin or amphotericin, and it's usually for months. So median time for treatment is 9 months, and really we treat until there's radiographic improvement. So just an important entity to be aware of in potentially your neutropenic patients upon count recovery, that this is a chronic disseminated form of candidiasis. And so, in summary, candidal infections are the most common types of fungal infections in cancer patients. Cancer patients are at increased risk for infections due to Candida because of the many risk factors that we've outlined: neutropenia, breakdown of the mucosal barriers, presence of central venous catheters, total parenteral nutrition, and others. Clinical manifestations really vary from local mucocutaneous disease to invasive disease. And management of some of the invasive forms of candidiasis include echinocandin therapy and removal, again, of those catheters or addressing any other foci of infection. And again, with widespread use of azole antifungals, either as prophylaxis or more use of echinocandins, we are seeing the emergence of more non-Candida albicans species. So just important things to keep in mind when you're empirically treating your patients for a candidal infection. And so that's all I had. I very much appreciate your time and look forward to your comments and questions at the end of the session. Thank you.
Thank you very much, Dr. Anam Abbas, for an excellent talk and giving us an overview of candidal infections in cancer patients. So now we will move on to our next talk, which will be antibiotic-resistant gram-negative bacterial infections in patients with cancer. And our speaker is Dr. Azra Parveen. She is a consultant in infectious diseases and general medicine at Shaukat Khanum Memorial Cancer Hospital, Lahore. Over to you.
Bismillahirrahmanirrahim. Assalamu alaikum. The topic of my presentation is antibiotic-resistant gram-negative bacterial infections in patients with cancer. I will begin with introduction to antimicrobial resistance, some basic definitions, the burden of antibiotic resistance in patients with cancer, and then the mechanisms of antimicrobial resistance, the treatment options available, and the prevention. Infection is one of the leading causes of death in patients with cancer. Loss of efficacy of antibiotics due to antimicrobial resistance is an urgent threat to the continuing success of cancer therapy. The history of antimicrobial resistance dates back to the discovery of penicillin. So the penicillin was discovered in 1928 and the production began in 1945, and within 2 years after its production, resistance to penicillin was encountered. Alexander Fleming, during his Nobel Prize speech in 1945, had predicted the development of resistance to penicillin. And he said that the time may come when penicillin can be bought by anyone in the shops, and this will lead to ineffective concentrations of the drug in the body, and that will promote antibiotic resistance. This figure shows the antibiotic timeline. The upper part shows the time when the antibiotic is introduced, and the lower part shows the time at which the antibiotics were identified. And we can see that the penicillin was introduced in 1943, and penicillin-resistant staph was discovered in 1962. Penicillin was introduced in 2000, and very soon, a year later, linezolid-resistant staph appeared. Ceftaroline introduced in 2010, and only a year later, there was development of ceftaroline-resistant staph. So the global burden of infections resistant to existing antimicrobial medicines is showing an alarming pace. And in 2015, WHO declared antimicrobial resistance as a growing global threat. And it is predicted that if the antimicrobial resistance keeps on growing at this rate, then there will be around 10 million deaths by the year 2050. And this will be more than the deaths caused by cancer. And this will significantly affect the treatment of immunocompromised patients, like those with cancer and those having organ transplants. So how do we define antibiotic resistance? It is defined as the ability of the microorganisms to survive when exposed to antibiotics that usually would kill them or prevent their growth. A bacterial strain is said to be susceptible to a given antibiotic when it is inhibited in vitro by concentration of this drug that is associated with a high likelihood of therapeutic success. And a bacterial strain is said to be resistant to a given antibiotic when it is inhibited in vitro by a concentration of the drug that is associated with a high likelihood of therapeutic failure. And a multi-drug resistant isolate is one that is resistant to 3 or more different classes of antibiotics. The antibiotic resistance can be intrinsic or acquired. Intrinsic resistance it can be an inherent feature of a microorganism resulting in the lack of activity of a drug or a drug class. It may result from the lack of the appropriate antimicrobial target. It may be because of the inability of the drug to access the bacteria. An example is the intrinsic resistance of gram-negative organisms to glycopeptides like vancomycin glycoplanin, because glycopeptides not penetrate the outer membrane to reach their target. Acquired resistance results from a change in phenotypic characteristics of an organism, leading to decreased effectiveness of a previously active drug. In 2017, WHO published a list of bacteria for which there is an urgent need to develop new antibiotics, and these were classified into 3 categories as critical, high, and medium, depending upon the degree of priority. And priority 1 group is the critical one, where it includes most of the gram-negative resistant organisms like Acinetobacter, carbapenem-resistant Acinetobacter, carbapenem-resistant Pseudomonas aeruginosa, and carbapenem-resistant Enterobacteriaceae. So these are the group of bacteria which I'll be focusing on in today's talk. The factors to antimicrobial resistance, the main thing is the misuse of antibiotics in human and then overuse of antibiotics in animals, antibiotics used in food industry and in agriculture, poor hygiene, the lack of diagnostic rapid procedures that results in a delay in definitive diagnosis, and prolonged use of empiric antibiotics. Right now we're talking about the burden of antibiotic resistant patients with cancer. So the burden of antibiotic resistance in cancer patients is enormous, and it has significant effect on the outcomes and mortality. Infections are one of the most frequent complications seen in patients with cancer. Cancer patients are not only at increased risk of developing an infection, but they are also at an increased risk of dying from an infection. A patient with cancer has a 3 times greater risk of dying from a fatal infection than a patient without cancer. This table shows the factors that increase the risk of infection in patients with cancer. The first and most important is neutropenia, resulting from chemotherapy, radiation therapy, bone marrow infiltration with tumor or drugs. Then disruption of the normal anatomic barriers, for example, caused by chemotherapy resulting in mucositis, radiation therapy, use of vessel access catheters, urinary catheters, gastrostomy tubes. So all these things result in disruption of the normal anatomic barrier and make a patient more prone to develop infections. Then obstruction due to primary or metastatic tumor, obstruction of the airways will cause obstructive pneumonias, lung abscess empyema. Obstruction of the biliary tract can cause ascending cholangitis, hepatic and pancreatic abscesses. And there may be bowel obstruction, necrosis, perforation, and urinary tract infections, abscess, and prostatic abscess. Then the use of various devices and the surgical procedures also increase the risk of infection, like surgical site infections, wound adhesions, then the CNS shunt infections, and then the infections associated with various prosthetic devices. And then there are the miscellaneous factors like age, nutritional status, and prior antibiotic exposure. So this is a systematic review and meta-analysis of the global prevalence of carbapenem-resistant neutropenic patients and association modality and carbapenem use. So in this systematic review, a total of 30 studies were included, and the overall carbapenem resistance varied from 2% to 53%. Carbapenem resistance appeared to correlate with mortality and previous exposure to carbapenems. So carbapenem resistance represents a threat to neutropenic patients, and in this group, resistance is likely promoted by previous carbapenem use and leads to high mortality rates. This is a study about the epidemiology and outcome of bacteremia caused by drug-resistant escape pathogens. So escape pathogens include vancomycin-resistant streptococcus, methicillin-resistant Staph aureus, ESBL-producing Klebsiella pneumoniae, carbapenem-resistant Acinetobacter, carbapenem-resistant Pseudomonas aeruginosa, and ESBL-producing Enterobacter. So in the study, it was found that those patients who had infections caused by these escape pathogens, they had a high incidence of persistent bacteremia and a high incidence of septic metastasis and an early case fatality rate when compared to patients who had infections caused by other organisms or less resistant organisms. This is a retrospective descriptive study about the impact of hospital-acquired infections in patients with multi-drug resistance in an oncology intensive care unit. And the overall prevalence of MDR, healthcare-associated infection, was 39.5%. Amongst all the patients to ICU, 252 patients died, and death was related to healthcare-associated infections in 23% of these patients. Number of the patients were 58, and out of these 58 patients who had healthcare-associated infections, 51 patients had an MDR organism. So critically ill cancer patients admitted to the ICU are at a major risk of a bacterial MDR healthcare-associated infection, and this will adversely impact the mortality. So this is another retrospective study about the bloodstream infections with gram-negative organisms and the impact of multi-drug resistance in patients with hematological malignancies. So the study included around 109 patients who had bloodstream infections caused by gram-negative bacteria, and the main outcome was overall survival at 30 days. Most of the patients had infections by Enterobacteriaceae, which include E. coli, Klebsiella, Enterobacter, Citrobacter, and 26% patients had infections with non-fermenting gram-negative bacteria, which are Pseudomonas and Acinetobacter mainly. So the overall survival rate at 30 days for patients who had infections by the non-MDR organisms was 85%, but it was significantly low for the patients who developed bloodstream infections caused by MDR organisms. Here I would like to share the antibiogram of Shaukat Khanum Hospital for the years 2015 to 2020, and I would like to say thanks to Dr. Sumaya Nizamuddin, who is a consultant microbiologist at Shaukat Khanum Hospital, and Mr. Rehan, the ID pharmacist, for providing this information. So this is the sensitivity pattern of E. coli for the various antibiotics from the years 2015 to 2020, and we can see the sensitivity of carbapenems for E. coli was around 96% in the year 2015, and it has now dropped to 79%. Similarly, as the sensitivity was 78% in 2015, which has now dropped to 60%, which is quite alarming. The sensitivity for ciprofloxacin and ceftriaxone is always very low, it's around just only 20%. Fosfomycin and nitrofurantoin are useful drugs against E. coli, and mainly these are used for the treatment of urinary tract infections. The sensitivity pattern for Klebsiella pneumoniae is better as compared to E. coli, as like 84% strains are susceptible to carbapenem, 71% to Piptas, and again, the sensitivity for quinolones and cephalosporins is low. And Pseudomonas aeruginosa, the susceptibility to carbapenem is around 87-88%, and Piptas is also 80%. And if we see over the past 5 years, there's not been much change in the susceptibility of Pseudomonas aeruginosa. So now we'll talk about the mechanisms of antimicrobial resistance in gram-negative bacteria. So beta-lactam antibiotics are the main group of antibiotics which are used to treat infections, and in fact the most potent ones. And these include penicillins and the derivatives, the cephalosporins, monobactam, which is estrogen, and the carbapenems, imipenem, meropenem, ertapenem, and toripenem. So the mechanisms of resistance, the main mechanism of resistance is expression of beta-lactamases, which break down the beta-lactam ring and thus make these antibiotics ineffective. I will talk about the various beta-lactamases in detail later. Then there is decrease in permeability of the bacterial cell wall that will not allow the antibiotics to enter the bacteria. And then there's the presence of the efflux pumps, which will actively move the drug out of the bacteria, and then the modified penicillin binding protein targets, which is more relevant to gram-positive bacteria and results in the resistance to penicillin. So this is the structure of gram-negative bacterial cell, and this is the outer membrane, which is a lipid polysaccharide bilayer. It contains porine channels and the efflux pump. So porine channels promote the entry of the hydrophilic antibiotics like beta-lactams. In certain bacteria, there may be reduction in the number of these porine channels, or there may be mutations that change the configuration of these porine channels so that the antibiotic cannot enter the bacteria, or there are the efflux pumps which actively move the antibiotic out of the bacteria. Then there's a periplasmic space which contains the base beta-lactamases, and these beta-lactamases inactivate the beta-lactams. And then in the cytoplasm, we have the chromosome and the plasmid switch heavy gene for the various drug resistance mechanisms. So talking about the beta-lactamases first appeared in 1960 and 1970s, and these conferred resistance to the penicillins, aminopenicillins, and the other spectrum cephalosporins. However, these responded to expanded spectrum third generation cephalosporins like ceftriaxone, cefotaxime, ceftazidime, monobactams, and carbapenems. In early 1980s, ESBLs appeared, that is extended spectrum beta-lactamase. So the presence of extended spectrum beta-lactamase will make a bacteria resistant to third generation cephalosporins and estronam. And the preferred treatment option for these bacteria is carbapenem, or a carbapenem sparing option would be a beta-lactam and a beta-lactamase inhibitor combination. We'll talk about these later. And then are the carbapenemases, which appeared in 1990s. So the bacteria which can produce carbapenemases, they become resistant to carbapenems. And these carbapenemase producing organisms are also frequently resistant to most other classes of antimicrobial agents. And so there are very limited therapeutic options available to treat such infections. This is the Ambler classification of beta-lactamases, which divides them into serine beta-lactamases and the metallo-beta-lactamases. And these are further classified as class A, C, D. Metallo-beta-lactamases are class B beta-lactamases, and this includes the NDM, the New Delhi metallo-beta-lactamases. So we'll start with these class B beta-lactamases, the metallo-beta-lactamases, but because these are more prevalent in our part of the world and hence more relevant to us. So the presence of metallo-beta-lactamase will hydrolyze all penicillins, cephalosporins, and carbapenems, but estronam still remains effective. These metallo-beta-lactamases were first discovered in India, and then they spread globally, and are also found in other parts of the world. The treatment options are very limited, and experts should always be consulted for the management of such infections. And these are the various options available. Combination of estronam and ceftazidime avibactam, polymyxin B and polymyxin E, plazomicin, phosphomycin, and ceftriaxone. This is an article about the outcomes of the Klebsiella pneumoniae carbapenemases bacteria and the outcome of the various antibiotics. So a relatively older study does not include the recent newer beta-lactamase inhibitor combinations. The success rate for aminoglycosides in the study was 75%, polymyxin combination was 73%, tetracycline 71%, and quite low for carbapenem and polymyxins alone. So estronam is a monobactam beta-lactam antibiotic. It is active against gram-negative organisms, but is not active against gram-positive or anaerobes. A very important thing is that it is not hydrolyzed by the metallo-beta-lactamases, so it can be used for for the treatment of diabetic ectamesis, but in combination with ceftazidime avibactam. This is a prospective observational study about the efficacy of ceftazidime avibactam plus estrogen in patients with bloodstream infections caused by diabetic ectamesis. The aim was to compare the outcomes of patients with bloodstream infections with ectamesis who received either ceftazidime avibactam estrogen combination or other active antibiotics. So the other active antibiotics were carbapenems, fosfomycin, tigecycline in various alone or in various combinations. So in total, there were 102 infections, 102 patients with bloodstream infections, and 82 of these had infections caused by NDM-producing strains. The primary outcome measure was 30-day all-cause mortality, and it was found that 30-day mortality was 44% in patients who received the other antibiotics, but it is 19.2% in the patients who received the combination of ceftazidime avibactam estrogen. And the figure shows the cumulative survival of ceftazidime avibactam estrogen combination was much better as compared to the other agents. And also the clinical failure at day 14 and the shorter length of stay for the patients who received this combination. So at present, the recommended treatment for diabetic ectamesis is a combination of estrogen with ceftazidime avibactam, but unfortunately both of these drugs are not available here. So ceftazidime avibactam is basically a third generation cephalosporin in combination with the beta-lactamase inhibitor, and this avibactam protects ceftazidime against the degradation by ESBL and cephalosporinases and KPCs. That is Klebsiella producing carbapenemases, Klebsiella pneumoniae carbapenemases. Ceftazidime avibactam is approved for treatment of complicated urinary tract infections, complicated intra-abdominal infections in combination with metronidazole, and hospital-acquired and ventilator-associated pneumonia. It's a comparative study of colistin versus ceftazidime avibactam for the treatment of infections to carbapenem-resistant Enterobacteriaceae. 46% of the patients had bloodstream infections, and 22% of the patients had infections with the respiratory tract. And the all-cause hospital mortality at 30 days was 32% for the patients who received colistin, but only 9% in patients who received ceftazidime avibactam, and this was statistically significant result. So now we'll talk about polymyxins. These include polymyxin B and polymyxin E. Polymyxin B and polymyxin E both have the same antimicrobial spectrum, but they both are different pharmacologically. Polymyxin B has an easy dose calculation, and the therapeutic serum concentrations are achieved more rapidly with polymyxin B as compared to polymyxin E. And also there's a lower patient-to-patient variability with polymyxin B in the pharmacokinetics. So the polymyxin B is preferred for IV therapy for bacteremias with carbapenem-resistant organisms, but polymyxin B is not available, and we only have polymyxin E by the name of colistin. Polymyxin B should be avoided in the treatment of UTI because it's treated by kidneys, and also it is not recommended for inhalation therapy. So polymyxin E or colistin should be used for UTI and when it has to be used as an inhalation therapy. So polymyxin B and polymyxin E are effective for infections caused by metallo-beta lactamases, but these have to be used in combination with carbapenems. And the rationale is that the polymyxins have sort of a detergent effect on the cell membrane, and they increase cell permeability and will allow rapid penetration of carbapenems. So colistin binds to lipopolysaccharide. It disrupts the outer membrane and allows the carbapenem to enter the bacteria and exert its action. This is a study about the importance of combination therapy. that is using colistin alone or using colistin combination with carbapenems. And it was found that patients who received monotherapy with polymyxin, they had a higher 30-day mortality as compared to the patients who received a combination therapy, combination of carbapenem with colistin. This is a retrospective cohort study from Lancet about the effect of appropriate combination therapy on mortality of patients with bloodstream infections due to carbapenem-resistant organisms. And here they found that the overall mortality was not different between those who received combination therapy or monotherapy. However, when the patients who had high mortality score, they were analyzed separately, it was found that they had a better outcome when they were given a combination therapy. But this effect was not seen in the patients with low mortality score. So the general recommendation is that patients with that carbapenems should be used in combination with colistin. However, there's another randomized controlled trial that favors the use of monotherapy with colistin. It is a multi-center open-label randomized controlled trial when the patients were randomly assigned to use to intravenous colistin alone or colistin with meropenem. 406 patients were included, and most of the patients had pneumonia or bacteremia. And the very important thing here is that most of the infections in these patients were caused by Acinetobacter. The kidney failure at 14 days with just monotherapy and combination therapy was not different. We must keep this thing in mind that this trial, most of the patients had Acinetobacter, and the trial was unpowered to specifically address other bacteria. So the results are not visualized to all the gram-negative bacterial infections. Then another recommendation about beta-lactam antibiotics is to use them as a prolonged infusion, a continuous infusion over the entire dose interval, or as an extended infusion over 2 to 4 hours. And this is based upon the pharmacodynamic principles that beta-lactams demonstrate time-dependent killing. So larger the time, the concentration of the drug in the blood is above the MIC, the better will be the outcomes. Now, fosfomycin, one of the antibiotics that is recommended for the treatment of carbapenem-resistant organisms. It inhibits cell wall synthesis, and it is bactericidal with time-dependent killing. It should also be used as a combination therapy. And IV fosfomycin is used for bacteremias, but oral fosfomycin should only be used for the management of urinary tract infections. Plazomycin is a semi-synthetic aminoglycoside, and it can be used for the management of complicated UTIs and acute pyelonephritis caused by Enterobacteriaceae, including multi-drug-resistant strains. And this is based on a randomized non-inferiority trial of 609 patients who were randomized to either receive plazomycin or meropenem. And the composite cure at day 5 and day 15 to 19 days was not different between the two groups. However, plazomycin has variable activity in Pseudomonas, and it is not active against Acinetobacter. And also to keep in mind, this is only recommended for treatment of complicated UTIs and pyelonephritis and not for bacteremia. A few words about tigecycline. It is licensed for the treatment of skin and soft tissue infections, intra-abdominal infections, and community-acquired pneumonias caused by carbapenem-resistant infections, bacteria. However, there's a black box warning about a higher risk of death among patients with tigecycline as compared to other antibacterial drugs. The recommendation from FDA is to reserve tigecycline in situations where alternative treatments are not available. And then cefiderocol, it is a novel cephalosporin. It can be used for the treatment of carbapenem-resistant pathogens, and it is recommended for the treatment of hospital-acquired pneumonias and complicated urinary tract infections and pyelonephritis. So I would like to point out here that so far all the antibiotics which I have mentioned, only carbapenems and colistin, colistin polymyxin E are available in Pakistan, polymyxin B is not available, and fosfomycin the availability of fosfomycin IV is also variable. All of the other things which I've mentioned so far are not available in Pakistan. Now we move on to the class A beta-lactamases. These are mainly the Klebsiella pneumoniae carbapenemases. These refer to all beta-lactams. The resistance is mainly plasmid mediated, mainly found in Klebsiella pneumoniae, but may be found in other Enterobacteriaceae, including E. coli, Klebsiella, Oxytopa, and also in Pseudomonas aeruginosa. The treatment options are the beta-lactams and the non-beta-lactams, beta-lactam and the beta-lactam inhibitor combinations, which include ceftazidime avibactam, as we already talked about, meropenem bifidobactam, and imipenem relebactam. So all these beta-lactam antibiotics, they owe their activity to the beta-lactamase inhibitors. These beta-lactamase inhibitors will inhibit the beta-lactamase enzyme, and in this way they will these antibiotics and exert their action. The non-beta-lactam options are plazomicin, fosfomycin, and polymyxin B, and for UTI, polymyxin E. So, meropenem bifidobactam is a combination of meropenem with the beta-lactamase inhibitor. It is approved for the treatment of complicated urinary tract infections, including pyelonephritis, non-Hepatitis, Pseudomonas aeruginosa, and Acinetobacter. This is study about the effectiveness of meropenem bifidobactam against gram-negative isolates, and it was very active against 1/3 KBC producers. Again, the combination and limited activity against isolates producing beta-lactamases. Imipenem/relebactam, again a combination of a beta-lactam with a beta-lactamase inhibitor, FDA approved for hospital-acquired and non-infectious pneumonias, complicated urinary tract infections, and complicated intrabronchial infections. It is active against Enterobacteriaceae, Bacteroides, and also Pseudomonas aeruginosa. Again, all these beta-lactamase inhibitor combinations, which I have mentioned so far, are not active against beta-lactamases. And with the addition of relebactam, imipenem plus FD is increased from 8 to 88%, which is quite significant. Another beta-lactam beta-lactamase inhibitor combination, ceftolozane tazobactam, advanced generation cephalosporin combined with the beta-lactamase inhibitor tazobactam. It is active against ESBL-produced Enterobacteriaceae and DR Pseudomonas aeruginosa, approved for the treatment of complicated intrabronchial infections and complicated UTI. And then move on to the class C beta-lactamases, which is basically MC beta-lactamases. These are present in Enterobacter, Citrobacter, Serratia, and Morganella. They may also be found in Pseudomonas aeruginosa and Acinetobacter species. So this MC enzyme may be induced, or the mutants hyperproducing MC may be selected for after exposure to cephalosporin. This is most commonly encountered in Enterobacter infections. So the patients who have Enterobacter infections, when they are treated with 3rd generation cephalosporins, they develop resistance while on therapy. So it is recommended that 3rd generation cephalosporins should be avoided for gram-negative bacteria that produce MC, which are these Enterobacter, Citrobacter. The most notorious is Enterobacter. And even if they are susceptible in vitro, we should avoid using cephalosporins for these infections. And the treatment options are carbapenems, fluoroquinolones, and these combinations of beta-lactam beta-lactamase inhibitor combinations. So, so far we've talked about the lactose fermenter, the Enterobacteriaceae. Then there are the non-lactose fermenters, organisms like Pseudomonas aeruginosa, Acinetobacter, and Stenotrophomonas multifida. Again, limited therapeutic options are available. There are various beta-lactam beta-lactamase inhibitor combinations, which we already discussed. Then polymyxins and aminoglycosides, and infectious disease consultation is always recommended when we encounter such infections. And this is a table to show the comparative activity of ceftazidime avibactam and Pneumonia against the various bacteria. And you can see that both of these are effective against Enterobacteriaceae, but not against Metallopetalactamases. So in our part of the world, mostly it is Metallopetalactamases. So probably even getting these new antibiotics will not be of much help for us. And then these beta-lactam, beta-lactam combinations are not effective against Acinetobacter or Pseudomonas aeruginosa. Now we come on to the strategies for prevention of antibiotic resistance. The first thing is antimicrobial stewardship, then infection control, and to minimize the use of invasive devices. So antimicrobial stewardship is based in effort to measure and improve how antibiotics are used, are prescribed and used by the patients, and it is very important to prevent antimicrobial resistance. There are some basic principles of optimal antibiotic use, which we should all be knowing. It is initiating the empiric therapies when the patient comes in emergency and we are not sure about the diagnosis. Based on the patient's presentation and the knowledge of the hospital antiviral, we start with empiric therapy and send all the cultures, and when the culture results are available, you tailor your antibiotics based on that. I would like to mention about the discontinuation of empiric antibiotics before absolute neutrophil count recovery. So this is a study from the Annals of Hematology about de-escalation of empiric broad-spectrum antibiotics in hematopoietic stem cell transplant recipients with Neutropenia. And it was found that early de-escalation of empiric antibiotics for Neutropenia to levofloxacin prophylaxis is a safe management option for allogeneic or autologous stem cell transplant patients. During Neutropenia who are really stable, who remain AF for at least 48 hours, or who don't have any documented infection. The patients, it was obviously a prospective observational study, and there was one group in which early de-escalation was done. That is, a broad-spectrum antibiotic was de-escalated to levofloxacin prophylaxis once the patient was afebrile for 48 hours, even though he was neutropenic. And then there was the standard of care group in which the broad-spectrum antibiotic was continued during the whole duration of neutropenia. It was found there was no significant difference between the ones identified, and the outcomes like ICU transfer, mortality were also not significantly different between the two groups. It is also important to convert from intravenous to oral antibiotics as soon as the patient is able to take oral medications. Use the shortest effective duration of therapy and the pharmacokinetic monitoring to ensure appropriate drug levels in the blood, and also to know about the drug toxicity. Then another important intervention for control of these antibiotic-resistant organisms is infection control. And the most important thing in infection control is the hand hygiene and transmission-based precaution that is used of contact precautions, gloves and gowns whenever you see such patients. And apart from the measures which we use or which we can take in the healthcare setting, there are some other things which are needed to reduce the antimicrobial resistance, and this is legislation against the drug misuse and the poor quality of drugs and the over-the-counter availability of the drugs and the use of antibiotics in animal feed. All these factors have also to be taken care of if we have to reduce the antimicrobial resistance. The active surveillance linked of virus patients to rectal colonization can be done. It is very useful in the setting of outbreaks due to CRE. And in conclusion, I will say that antimicrobial resistance is a global threat. We need a coordinated effort from government, healthcare, industrial sector. New antimicrobials will not be available in Pakistan for years, will not be affordable. And as I mentioned earlier, even if they will be available, all of them will not be helpful. We must improve our infection control and hygiene standards and establish antimicrobial stewardship programs to ensure that remaining antibiotics are used judiciously. I thank you all and happy to take any questions.
Thank you very much, Dr. Azra, for a very detailed overview of antibiotic-resistant gram-negative bacterial infections and available antibiotics. So I believe we have the panelists with us, so we can start the question answer session. If we can unmute the panelists' mic, please. So first of all, thank you very much for all the panelists for participating in this symposium, and especially Dr. Anam for participating in this session so late. Thank you very much.
No problem at all. Thanks for having me.
Okay, so I have a few questions. First question is for Dr. Ijaz. This is from Dr. Halima. So what is the role of galactomannan assay in diagnosis of invasive fungal infection? Should it be sent on blood or BAL specimen?
Thank you. Good question. I think I've already answered in my presentation as well, that galactomannan is should be used in blood. It is available in BL centers which would do it, but I don't think it is available in Pakistan, at least not in my center. So galactomannan, pretty sensitive, very good marker, and I think a lot of centers are already using it.
Right. So there is another comment for Dr. Ijaz that by Dr. Ashraf Ali. Dr. Ijaz mentioned 2 antibiotics for pseudomonal pneumonia in neutropenic children. So he says peers may have this approach, but we have been using single agent. So your comments or thoughts?
Yes, I agree with Ashraf that single monotherapy is now being recommended in most centers, and we're using it as well. It is just one of the recommendations in one of the tables that I used it, but you don't have to use it, especially like immunoglycoside. I don't use it especially in lung infections for pseudomonal therapy. Single drug is alone should be enough. Ciprofloxacin is an option for standalone therapy, as well as an oral option in a lot of infections in which you can de-escalate to oral option. So I think you can use a single therapy.
Right, thank you very much. So I have another question for Dr. Ijaz. Can you please comment on the duration of antifungal therapy for proven fungal lung infection in pediatric oncology patients? This question is from Dr. Alina, and yeah.
So in a short question, I think it is a long therapy. So usually 6 weeks or up to 3 months are at least is given till you see a good, reasonable clinical, bacteriologic, and inflammatory marker response. And I think the therapy can be extended even beyond 3 months. For example, like certain mucor, which can go on for about 6 months as well. And of course, then they are put on prophylactic therapy, which can be even longer than that. So a longer therapy, and at least if you see clinical improvement, 6 weeks in minimum, but I think in neutropenic immunocompromised, longer therapy is what is usually being practiced, and that's how you see the response.
So, I mean, should we repeat CT thorax at 6 weeks to see the resolution? And if
well, you can actually I don't do imaging till I am kind of de-escalating or stopping my therapy. Only then I would probably do the imaging of whatever the organism was, whether it's a lung or whether it's sinuses. Only then I would do imaging. Yes, if it has been an extensive disease, then of course you would do periodic imaging as well, just to make sure that you are going in the right track, at least imaging-wise. Clinically, of course, you will be you're much more capable of doing that in your clinical follow-up.
Okay, thank you very much. So I have a question for Dr. Anam. This is again from Dr. Alina, and the question is: we often see Candida in smear done for urine culture. How common is Candida UTI, and what is the treatment and duration recommended in immunocompromised patients?
Yes, that's an excellent question. I think the important thing to remember with Candida in the urine is really just sort of teasing out if this is asymptomatic candiduria or if this truly is a UTI secondary to Candida. that's an important distinction to make because Candida can just be a colonizer and doesn't necessarily require treatment. And the presence of Candida in a smear or even in a culture doesn't indicate infection itself. So you really have to put it into clinical context. You know, are they having those typical lower urinary tract symptoms? Any signs of ascending infection concerning for pyelo? Or do they actually have invasive candidiasis? We have a lower threshold to treat in our immunocompromised patients. Obviously, if they're neutropenic, they might not mount the same inflammatory response, and so they may not present with those same symptoms. And so in general, we have a lower threshold to treat them. But I would just preface it by, you know, you have to just kind of be careful not to treat every culture or smear that you see, as a lot of this may represent asymptomatic colonization. And then as far as treatment, if you do determine that this is truly an infection and you'd like to treat it, there are limited options. Fluconazole concentrates well into the urine, so that's an option. But if you have a species that's fluconazole resistant, then you're kind of in a bind. Other options are flucytosine and ampho. So there's not great options. The echinocandins don't concentrate, don't get into the bladder, don't get into the urine. So that's not a great option. And so probably azole, amphotericin, or flucytosine are your options. And then depending on if this is an uncomplicated UTI, you could probably treat for 7 days or so. If it's a complicated UTI or they're fungemic, then obviously you would treat longer, probably a minimum of 14 days.
Yeah. All right. Thank you. So I have another question. This is from Dr. Halima. And what antifungal should be used for Candida lusitania since it is resistant to amphotericin B?
Yeah, that's a great question. That's why it's important to get the speciation because really your empiric antifungals can really be important in cases of candidemia. Here we use micafungin. So we start when we have candidemia or an invasive candidal infection, we start micafungin because you kind of have more bang for your buck. You're more likely to cover more of the species. I'm not sure, you know, if that's widely available in Pakistan.
So this is actually one of the another question. So I don't believe that micafungin is available in Pakistan. So we have caspofungin, but we do not have micafungin.
Yeah,
but
any echinocandin, capsifungin would be acceptable.
Yes, but issue is the cost. So the caspofungin, it's really very, very expensive. And in our setup, I mean, since the cancer patient, they're on support and the hospital provides us, but outside, I think it's very difficult for patients to afford the caspofungin.
Of course. Fluconazole, then obviously I think would be probably your most choice.
Yeah. So I have another question for you. Can we use serial beta-D-glucan to monitor therapy response? Do higher values correlate with poor prognosis?
Yes, we absolutely can use beta-D-glucan to monitor therapy to response. In cases of invasive aspergillosis or candidiasis or even pneumocystis, you can start off with really elevated levels and you can definitely see those fall with appropriate treatment. And so that is something that will fall. It's not something that I'll check every day, but probably maybe like, 2 to 3 week intervals just to kind of see the trend. It's not something that you would need to check that frequently, but it should come down with appropriate treatment.
Right. I have another question for you. So you mentioned vitrectomy. So at what point of antifungal therapy we should consider vitrectomy?
I don't know if I'm equipped to answer that because we get the ophthalmologists involved, as soon as we have a case. So that's kind of their scope. So I'm not sure if I would answer this appropriately, but in our practice here, if we have a patient that, is presenting with candidemia, it's just, standard practice to get the ophthalmologist involved so that they can do their dilated eye exam and then they kind of take it from there.
Right. Okay. So I have a question, Dr. Ezra. I think you can answer this. Some centers use daily chlorhexidine bath for pediatric oncology patients to reduce rates of nosocomial infections, including CLABSI in patients. Is this something being considered at SKM? So first, Dr. Azra, I'll request Dr. Ijaz as well to comment on this question.
So fluoride bath is something which is recommended for prevention of infections. It is being done routinely in ICU part of the VAP bundle. But other than that, not been done. We're also doing it for the pre-operative patients to reduce the risk of cellular site infections, but not for everyone.
Right. Okay. Dr. Ijaz, what about at Shifa Hospital?
I did not get the full question. What is it?
So the question was that some centers, they use daily chlorhexidine bath for pediatric oncology patients to reduce the rates of nosocomial infection, including CLABSI. So they are asking for our experience at SKM. So Dr. Azra she has responded to that question. But what's the practice at Shifa Hospital?
No, we have not used this. We have not, at least not as a routine. It could be an exceptional case, but we have not used it.
Okay. Okay. Thank you. And so I have another question. So Dr. Azra, probably you can answer this. How Shaukat Khanum is looking forward to manage resistant bugs that are originating due to malpractice in community?
So this is very unfortunate that because of misuse of antibiotics, there's a loss of antibiotic resistance in the community. And not much can be done on our part. What we can do is that we have antibiotic stewardship program. It's a very robust program where we are actively involved in the management of the infections and the antibiotics. So probably that would help. One thing I want to mention here is that there is a national task force on antimicrobial resistance. We have recently been set up, and it's like it's starting the surveillance and making a database for the different organisms from different hospitals. And then they're also conducting some workshops on antibiotic stewardship and lab-based practices. So I think all these efforts on a national basis that will help prevent antimicrobial resistance.
Thank you. I think I have a question for Dr. Anam. Fungal infections is a huge hindrance in our acute leukemia chemo patients. Some have fungal infections along with bilirubin as high as 13. So what's your choice of antifungal? Will you use, I think there are two questions. What's your choice of antifungal in such situation? And will you use dual antifungals?
Yeah, it's a great question and very pertinent in our patients. Unfortunately, a lot of our oncologic patients have elevations in their liver function, their liver enzymes, or their bilirubin, and it's something that we face frequently. I think probably the best, what I would say is that it really just depends on what fungal infection, what is their organism, and where is their disease. So is this, a chronic disseminated form of candidiasis? Are we dealing with an invasive mold infection just limited to the lungs, or is this a more disseminated mold infection? So I think a lot of things would probably matter. What I would say is that if the patient is severely immunocompromised, they've got a severe fungal infection, that's going to kill them before their elevated bilirubin. And so it's probably important to give them the most appropriate therapy, and then you kind of deal with the after effects. That's what I would say. Unfortunately, all of the antifungals that we have available to us, the triazole antifungals will cause liver dysfunction, and amphotericin can cause liver dysfunction. So we don't have great options. The echinocandins are probably the best, but as you mentioned, they're not widely available in Pakistan. And so these are difficult situations. They're difficult patients.
Yeah. Okay. Thank you. So Dr. Ijaz, I have another question for you. Yeah. So what is your approach for neutropenic pediatric patients with esophagitis? Should we use acyclovir or ganciclovir empirically, as endoscopy is usually difficult to do in young kids in Pakistan?
Oh, you got me on that. I think usually if you suspect viral etiology or CMV, only then you would do it. For example, usually Candida is much more common, I would say.
Yeah.
Yes. you can opt for antifungal therapy as and see the response, and then probably if you cannot do biopsy or histopathology, then you probably can give encyclovir or and then see the response according to that. So probably antifungal. If biopsies cannot be done, then a trial of antiviral is an option.
Right. Okay. Thank you very much, everyone. I think we are almost there, and we will conclude this session. Thank you very much, Professor Ijaz. Thank you very much, Dr. Anam, and thank you very much, Dr. Ezra, for participating in this session and making this session a success. I thank you all again, and we'll conclude this session.
Thank you.
Thank you.
Thank you very much. Bye-bye. Take care.
Thank you. Take care. Bye-bye.